All right, I'm Samantha Todd. I'm a physical therapist with St. Luke's. I work in downtown Boise. I'm also a pelvic health specialist, so I'm a pelvic and women's health clinical specialist. The goals for this learning session is to talk about the different types of pelvic floor dysfunction and how they relate to cancer treatments and survivorship, and then to give you an overview of just what we do in PT to treat this so you can prepare people who might be coming to PT, and then give you some tools for screening and interviewing patients about pelvic floor dysfunction. So I'm going to focus mostly on gynecologic cancer treatments. We'll touch a little bit on breast cancer, colorectal cancers, and prostate cancer as well. For gynecologic cancers, the type of cancer treatment modality really closely relates to the type, or is really predictive of the type of pelvic floor dysfunction we might see. So if somebody has surgery, we're going to think that they're suspect that they might have more structural issues like prolapse or stress incontinence because we're actually changing the structure. So in PT, we're going to work on pelvic floor training. We might look to our other providers for things like pessaries or surgical support if PT alone isn't solving their problems. For radiation, we're thinking that that's going to impact, uh, the function of the bladder, and so we're thinking they might have more urgency incontinence issues. We're thinking that they might have reduced bladder capacity, just radiating that tissue around it, and then looking for some vaginal stenosis that might lead to dyspareunia or painful intercourse. In PT, we're going to focus on like bladder training, pelvic floor function, and that's where we bring in dilators, and I'll talk about that. And some pharmacologic treatments can be supportive of that as well. For chemotherapy, we oftentimes see some more like neurogenic bowel and bladder changes and just changes in their sensory function. Um, we're going to work on bladder training and pelvic floor training for that. And then surgically, sometimes we see those patients getting like sacral nerve stimulators or other surgical supports if they're not making progress. As far as sexual health, we do use dilators a lot. And I always like to say that dilators, they can be uncomfortable, but they're not supposed to be painful. So if you talk to a patient and they're having some issues with sexual function and they're already given dilators, if they're saying that they don't like using them because they're painful, send them our way. But providing that information that we want to find a way for this to be comfortable is helpful. Um, Research also supports using global exercise alongside dilators. We also know sensory changes are common. So sometimes some pelvic floor training can help with that. The other thing we're talking to our patients about is, things might just feel different because your nerves are different, because your cancer treatment impacted that nervous system. So finding other ways, if what was working for you before isn't working anymore, finding other ways to find some sexual satisfaction. Integumentary support is really helpful here. So, vaginal estrogen, if that's appropriate, given a cancer diagnosis, can be really helpful. Otherwise, vaginal moisturizers and lubricants are really helpful. I know that people have talked a little bit about the body image and emotional health, but that's something in PT we're always screening for and trying to refer out for as well. So stress incontinence is when the pressure on the bladder is greater than the pressure on the urethra, so a person leaks urine. This is really common uh, after surgery. Your patients also may have had kids and then just losing muscle bulk over the course of cancer treatment. They're having stress incontinence that just wasn't there prior, but their life before cancer kind of set them up for it. Um, so we're working on strength training in PT, both of the pelvic floor and then just kind of improving their muscle mass and their uh, work capacity just by strengthening like kind of hips and lower extremities as well. And we talk about managing intra-abdominal pressure. So ways to move that put less pressure on the bladder can be helpful. And then supporting that connector slide. Um, is a great way to manage some of that stress incontinence. So these are people who are leaking when they're running, when they're lifting, when they're coughing, when they're sneezing. Um, Prolapse is also common. So that's where we've lost some of the support around the vagina, of the connective tissue. And so those organs are starting to fall into the vagina. And that can give the sensation of like a tampon coming out, pressure or heaviness or bulging in the vaginal area. We're working again on strength and coordination in PT. But a pessary is a great tool. And if you haven't heard of it, I like the analogy that it's kind of like a sports bra for your vagina. Um, I learned that in a con ed class, and I wish I could remember which one to give them credit for. But you're just taking something that there are lots of different kinds of pessaries, and that's something that a PT can talk to them about, but it usually comes from a gynecologist or a urogynecologist. And it's a non-surgical option for people who either just don't have the time right now to do pelvic floor therapy, or they aren't really like succeeding with that and just need a little bit more structural support, but don't want to go through another surgery. So it can be really helpful for people who are managing a lot of medical stuff. Um, Urge incontinence is when people feel like they have to go to the bathroom and they just aren't able to make it in time, or sometimes they're just having some like irregular bladder spasms and irregular urges. Chemotherapy can really impact people's sensations. And so this is something we see really commonly kind of during and after treatment. We're working a lot on people's bladder habits with this. Vaginal estrogen can also be helpful for this if that's appropriate. A lot of times people also just have a reduced bladder capacity. So we put them kind of on a voiding schedule. So we try to gradually stretch that bladder muscle a little bit so they can hold more without reaching the point where they're leaking. Um, just a plug for what normal is. It's normal to void 8 to 16 ounces every 2 to 4 hours. And it's okay if people aren't normal, if they have smaller voiding capacities, but kind of having an idea of what is sort of normal. And then waking 0 to 1 times at night. Fecal incontinence and constipation, we see a lot after colorectal cancers, but we also see it. Chemotherapy can impact people's um, GI motility, and just like the nausea meds that they give people can give them constipation. So we also see people's sensation change, especially after like a colorectal cancer, if they get like a bowel resection. Sometimes things are moving too fast, and then they'll have fecal incontinence. Um, so what we do in PT for that is we talk to them a lot about stool form. Basically, the best way to this is a plug for the squatty potty, a great tool to help put your pelvic floor in the better position to empty. We're working on strength. We're working on muscle overactivity. If people have had like rectal radiation, sometimes we're doing some manual therapy helping with that outlet. Um, and then we work a lot on sensory awareness, and we have a number of tools for that. Internal assessment is something that at St. Luke's we always offer our patients, but we have like EMG biofeedback if that's something that people are not comfortable with. So we never want people to decide that they don't want to come to PT because they don't want anyone down there. Like we have a lot of tools to help assess the pelvic floor and help people learn how to use it properly. Um, we sometimes will use rectal balloon training, which is an interesting modality where we can kind of use a balloon to help, like insert into the rectum to help teach sensation again. Um, I have recently been seeing a lot of people several years after breast cancer for urinary incontinence and sexual dysfunction, especially if they're on an estrogen blocker. It impacts their vaginal tissues. So that's something that in qualitative research studies, people want to be asked about and they want to know. So definitely screen these patients for pelvic floor issues. Prostate cancer, a lot of people have urinary incontinence after. Prehab is really well supported in the literature for this. So if you're seeing people before surgery, getting them going on a strength program can be really helpful. In the Treasure Valley, we send people to the Y for that. Sometimes insurance is funny about covering prehab. And we're doing a high volume of pelvic floor strengthening for that. So bowel, bladder, and sexual dysfunction are common with prostate cancer, colorectal cancers, and other cancers. So don't just screen women, screen men as well. Um, and if you're wondering what questions to ask, sometimes just asking, have you noticed a change in bowel and bladder habits? Letting people know that it's really common, but that there's something that we can do about it. Changes in your ability to control stool and urine are common. Are you noticing a change in how frequently you have to go to the bathroom? Is it harder to make it in time? Are you noticing staining in your underwear? Um, Changes in sexual function, sensation are also common. Do you have any concerns in that area? They did a big qualitative study that I cited at the end if you want to look at it, where, kind of the take home was that people want to know what's normal, and that asking frequently is helpful. This is called the Kazian screening tool, and it's a really helpful tool. It's validated in the general population for picking up on pelvic floor dysfunction. So if you don't feel comfortable talking about it, you can kind of hand this to people, and if they check at least three things, it's highly likely that they have pelvic floor dysfunction. You can just find that on the internet, or print it from my slides. And then being able to connect patients with resources. So we have St. Luke's has pelvic floor therapists in Boise, Meridian, Nampa, McCall, Twin Falls, and the Wood River Valley. There are a number of really fantastic private practices across the state as well. If you're kind of looking what to look for in your area, Herman and Wallace and the APTA Pelvic Health Academy provide a lot of really great evidence-based training. So kind of looking at where people are trained. I think it's optimal if people offer internal assessments. Not that everyone has to have an internal assessment, but it's definitely is a tool that should be offered for most of these patients. And if there are no pelvic health therapists in your area, educating people about what's normal is great. And then getting them started on a general exercise program usually does help with pelvic health issues. So my key takeaway is that pelvic floor disorders are really common after cancer. So ask early, ask often. Sometimes I put this picture of the seed because sometimes we're just planting a seed and it's going to grow later. But by educating people about kind of what's normal and what to expect, I think a lot of times people are just kind of happy to be alive after cancer treatments. So they'll put up with a lot of things that are really impacting their quality of life, not knowing that there's something that they can do about it. So if you can kind of plant that seed and water it frequently, that there's resources out there, I think it can be really helpful. And multidisciplinary treatment options, including pelvic floor therapy, are really great options. These are my references. And then, yeah, does anyone have any questions? I'm going to stop sharing for that.
Samantha, thank you so much for that fantastic knowledge burst. We have time for questions. You can unmute or you can use the chat. Amy, why don't you kick us off? Thanks.
Yeah, I'm curious for patients that are in the rural settings or where pelvic floor therapists may not be present. Is there anything virtual that you would recommend, education-wise or virtual assessments? I know I'm sure that's very difficult with pelvic floor therapy, but
Yeah.
I'm curious is there anything for our rural patients?
Yeah, that's a really great question. There are a lot of virtual clinics kind of popping up, and some insurances, like I've had a number of patients that have used Hinge Health, has some pelvic health, and honestly, like I think sometimes are helpful. It can be hard to know exactly who's getting better with those, but there actually is some great research for telehealth and that people can get better with that. The Pelvic People has a really good website. I can put that, type those into the chat. They have a really great website where they actually have some like remote PT options and some kind of online classes. And they have a really great blog about pelvic pain. It's not cancer specific, but they have some really great resources out there. The EPTA Pelvic Health website has some good articles and things too for people. Yeah, if I hear about anything else, I'll send that out too.
No, thank you so much.
Yeah. And we're always happy to be resources too. I mean, I'll sometimes get messages from providers saying, hey, there's no pelvic floor therapist in this person's area. Like, could you just send over some general recommendations? And yeah, we're happy to do that too.
Samantha, I tried to look those up. I think I have the right ones, but I'll let you put them in the
Okay.
chat. Thanks. Carrie, let's go to you.
I just wondered if you had like a basic screening, like questions that, the initial questions that we could approach patients with that.
Yeah, I think that one of the slide, I'm going to share it one more time and you can even
Okay.
just screenshot it. I'm going to go into presenter mode really quick. Sorry. So these screening questions, I think, are really great. And just straight up, you could just read them off to people. Basically, any changes in bowel function, any changes in bladder habits, and um, you know, any changes in sexual function. I just like to ask, do you have any concerns around sexual function? Sometimes people are like, I don't, because it's not something I'm engaging in right now. And that way it's a little more open-ended than like, do you have pain with intercourse? Well, they don't know if they have pain if they aren't doing it. And then this is that Cozy screening tool that if you want to even just like print that out, you can hand it to people.
Okay.
Yeah.
Any thoughts on I was trying to think of the name of the product where it's the implant, where there's some electrical impulse, maybe less therapy and more like a device that urologists are using.
Is that for men or women?
I think they're using it for both, for
Like a
urinary and bowel
like a
incontinence.
like a sacral nerve stimulator sounds.
Yeah.
Yeah, I think that those they do work well and there's really good research for them. That's definitely something that people are either getting from usually urogynecology or urology or colorectal surgeons will do that for people who are having bowel incontinence. And the idea is that it's kind of bypassing your brain having to communicate. And there's some really good research that supports it. Usually they'll put people through pelvic floor therapy and stuff first to see if they respond
Okay.
well to that. But if people are not responding well, it's definitely a good option for people.
Okay.
Yeah, people definitely do get results from that.
Let's go to you, Sam.
So you brought up general exercise a number of times.
Yeah.
I think maybe speaking to, for those who don't know, like, is that strength training? Is that cardio? Is it what? Like, what is general?
Yeah. So general exercise is the research articles are specifically more on a general strength program. So even giving people like sit to stand exercises, maybe a little hip strengthening, maybe a little core strengthening, maybe a little upper body. But walking is also helpful. And I think that's just meeting patients where they are and helping them find something that they can do that fits into their lifestyle. When I talk to people about general exercise, I usually like to ask, like, what do you like to do? And if they don't like to do anything, like what would you do? Because the best kind of exercise is something that you're going to do consistently. And then, yeah, if you want to give people kind of a general exercise program, I would say 2 leg exercises, 2 upper body exercises, and a core exercise is a great place to start. Yeah, these studies weren't looking at walking programs, but I know that Sam has probably spoken to you guys about that.
Any other questions or comments? Samantha, we in the breakout room, I was letting Samantha know Echo is looking in the future. So just putting a plug for 2027, we'll be launching a women's health focused series. And I know there's increasing interest. And so My question really is like for women who have undergone cancer treatment combined with perimenopause, menopause, like how do you in your role kind of tease that out and support
Yeah,
perimenopause, menopause, and cancer treatment and figure out what's happening that way?
that's a really great question because, most people have lived lives before cancer and they're, um, if they've had children, that's going to impact. And I think a lot of times, and I mentioned in one slide that their cancer treatment might just kind of be like uncovering something that was already there. Like maybe they already had a little prolapse or they had a little bit of like bladder changes. And so, but, just kind of some general decline in their health status is impacting things. I would say, in PT, it doesn't matter a whole lot to me how they got there. I'm really looking at like what are their impairments? Is this muscle tight? Is this muscle weak? Is your bladder capacity normal? Is it less than normal? And I think, being able to kind of explain to people all the different things that might be impacting that can be really helpful for them. But really, we're just trying to figure out what their general impairments are that are impacting their ability to do what they want to do, and then addressing that through exercise or lifestyle modifications.
And I think the additional plug I'd throw in there too is that I think a lot of times people go through this treatment and they, because of childbirth or whatever else in the past, think that leakage is normal or pain with intercourse is normal. And it doesn't get brought up a lot. And I think this is a population that gets particularly underreported in going through this. So I do think that screening piece and emphasizing that no, that's not normal is good.
Yeah, I like the term common, but not, or normal, but treatable, because we don't want people to feel like there's something wrong with them, but just knowing that they have some option for treatment if they want them, right? And I mean, these screening questions are great for all of your patients if you're seeing a non-cancer population as well. A lot of people, I had a woman the other day come in like, I just have mom bladder. And I was like, that's not a diagnosis. We can help you with this. Yeah. Megan, did you have a question?
I don't have a question. Can you guys hear me okay?
Yeah.
Okay, great. I don't have a question, but I did pelvic floor therapy after my cancer treatment. I was having issues with not being able to hold my bladder and urgency problems. And I kind of just thought I was gonna, and it was my entire body is weak. All my muscles are weak. They're stronger now, but it was something that I didn't even think was an option. And because of my age, I'm 34, I never had children. I didn't think that it was something that I necessarily needed, but ultimately it was so helpful, and not just for like full body and mind. The pelvic floor therapy was so great for me. So, I mean, if there's any sort of issues going on in that area, no matter what kind of cancer they had, if they went through any sort of cancer treatment or they've been sick for a long time, I highly recommend it. It's a little scary and intimidating at first, but it was really enjoyable actually, and I looked forward to it. So unlike chemotherapy, it was something that I really did enjoy, and I really got a lot out of, and I still do a lot of my exercises even to this day, and they've just become part of my regular health routine. And you cover a lot more than just like the physical aspects of what's going on. There's a lot of like spiritual and lifestyle stuff that you learn through the pelvic floor PT as well. So as somebody who's done it and who's gone through cancer treatment, I can't sing the praises enough. It's amazing.
Thank you so much for sharing that. Yeah, I think sometimes people are just really nervous because they don't know what to expect. And I was like, we're like generally pretty nice people that are just trying to like help you live your life. And we're not going to make anybody do anything that they don't want to do. We're just we're just here to help. So thanks for sharing that.